Hi. Okay, so Monia, I'll just introduce you and then I'll give over the floor to you. We are recording the session, so hopefully people can catch it later on YouTube. Um, so yeah, and so hello everyone, and welcome to the second week of Fair February. This year's theme is data science and social justice. And this week's theme is social justice in health. We're very delighted to have Dr. Monia Chopra with us today. Dr. Monia is a rheumatology fellow at the Roger William Medical Center. And today she's going to be presenting work joint with Dr. Gillick, who's also at the Department of Rheumatology. Over to you, Monia.
Thank you so much, Arishi. Hello, everyone. Good morning, and thank you so much for inviting me to share with you a very interesting case that was, though very challenging for us, but gave us and our department to actually learn a lot and gave us an opportunity to understand what are the challenges when you're dealing with a certain population group. So I would also like to thank Dr. Gillick. She's my program director and was involved in this case as well. So I will go superficially over the case and try to tell you what were the challenges and how we were able to overcome those hurdles. So just as a starting slide, as you know, I will be talking today about autoinflammatory diseases, and a little bit how this disease has become even more of a challenging situation when you're dealing with non-citizens or undocumented immigrants in specific with a rare disease. So that is the topic for me this morning. That's the healthcare of undocumented immigrants with rare diseases. So just to kick off my talk, I wanted to tell that we have a patient, a Hispanic undocumented immigrant, who presents to hospital every 2 to 3 months with symptoms including fever, abdominal symptoms, joint symptoms, and in order to work her up, she has been admitted over last 3 years. She first came to us in 2017, and since then till today, as you can see on your right side of the screen, these are the number of admissions in Rhode Island Hospital that the patient had to go till now. The most recent admission was almost a month ago, where we saw her and decided to take things in our hand much more aggressively than before. So now the patient has a working diagnosis of autoinflammatory syndrome or periodic fever syndrome that I will tell you in a bit what it is. And so the trend that this patient has been following since 2017 is the patient comes in with these symptoms that are debilitating for the patient and also are pretty critical and are carrying a huge burden of disease on the patient. So the patient comes in, gets full treatment, all the diagnostics, and then we plan everything very nicely and want the patient to follow up with the various departments on outpatient basis. But the patient is unable to do that and comes back right after a few months with the same complaints and same reasons. So with that being the introduction, I would briefly want to talk about what are these inflammatory diseases. So autoinflammatory diseases are a little bit newer diseases or newly categorized disorders. We, at least in rheumatology, have got a very good grip on autoimmune disorders. Initially, these autoinflammatory diseases were also thought to be like a part of the autoimmune diseases. However, now as more and more cases have been diagnosed, we have got a better sense of what these autoinflammatory diseases are. However, it is still a challenge to diagnose these diseases, especially when it goes to an adult population. In pediatrics, it's pretty remarkable. The symptoms are a little bit remarkable. The parents are good historians, they tell us, so it's easy to diagnose. However, in adults, the pattern can be not very typical and it can be a challenge for us to diagnose. So as I told you, it's a rare disease. It's a newly categorized disorder where there is a malfunction in the immune system secondary to the genetic mutations. And in this one, the innate part of the immunity is affected, as compared to in the autoimmune disease, it is the adaptive immunity that is effective. These diseases are generally seen in pediatric population. However, some diseases can present in adults as well. The symptoms most likely are fevers, rashes, joints and muscles pain, abdominal symptoms including as severe as peritonitis, constipation, diarrhea, systemic inflammation that we can see in the blood work. As you can see on the right side of the screen, I've put all these symptoms. It is not mandatory for each of the patient to come up with these textbook symptoms. They will not be typical, and they will be coming in every form and every way possible. So this is what is the broad category that we follow when we are treating someone with autoinflammatory disease. As easier said, it is a very, very difficult journey for both the patient as well as the medical team who have been treating this patient. So what are the challenges that we face when we are dealing with autoinflammatory disease? The first and foremost challenge is the symptoms are very non-specific. They resemble a lot of infectious disease and a lot of malignancies. So these people need a lot of workup when they come to the hospital to make sure that we are not missing out an infection or a malignancy that might be sitting somewhere. So unfortunately, these people undergo a lot of blood work as well as a lot of diagnostics. So the diagnosis is not a days or a weeks matter. For some patients, in a normal, typical, perfect scenario, it can lead from months to years, and can lead to an additional morbidity as well, which is what is happening with our patient. And then the patient's family, the patient do not understand these diseases because these are not common diseases that we deal on day-to-day basis. So the patients and the family know that something is wrong, but they just don't know what it is. And the doctors also fail to explain them what they're trying to find. On the right side of the screen, you can see some of the comments that were made by the patients who were diagnosed, or the parents of the pediatric patients who were diagnosed with autoinflammatory disease. And the sad part, or the sad reality of these diseases sometimes are, even though sometimes when we do have the diagnosis of the patients in our hand, still to find the treatment and what works best for the patient continues to be a challenge. So these are the few comments on the right side that were said to the doctors when the patients were diagnosed or were in the process of being diagnosed with autoinflammatory disease. I chose the top 3 of them because these comments did explain the difficulty that the patient was going through. So the first one I quoted was, the medical system was like a merry-go-round, endless doctors, tests, and drug, but absolutely no resolution. The other one was, without an advocate, I would never have gotten him the diagnosis. After we got diagnosis, I could look at people and say, see, I'm not crazy. Another one, my husband started to tell me I was imagining things. Other told me not to project my crazy on him. Many times you begin to even doubt yourself, wonder if this all is in your head. Sometimes you wonder if you had something that would never be diagnosed or would only be diagnosed on an autopsy. Heck, sometimes you wondered if you would ever know a day without pain. So as you can see from these comments, it's not only a physical pressure or the pressure from the disease that these patients face. It's also a lot of mental and peer pressure and social pressure that these patients go through. And this is one sad reality that now we are learning more and more. And this became very highlighted in our patient, who I'm going to talk about in the next few slides. So this is just the tabulated form of the chart that I saw show you in the very first image of my slideshow. So as I was seeing and I was looking through her admissions, I just wanted to know how much is her admission costing the hospital. So very bluntly, I just Googled how much is the cost of hospital stay per day, and averaging it around the hospital cost per day, it comes out somewhere around to be 2,607. It might be higher or lower depending on state, hospitals, and other stuff. But taking that as an average and computing it on the number of days this patient has spent only in Rhode Island Hospital for the past 5 years, starting from 2017, we have already spent almost $4 million on this patient just on hospitalization. So in 2000, and as you can see, the number of hospitalization days were not like 1 or 2 days or 1 or 3 days. Sometimes the patient was admitted for a safe discharge for more than 20 days as well, as you can see in 2018 and 2020. And almost all the time the patient was in the hospital for a minimum of 5 days. So this slide does show you how much of a economical burden the patient is also putting on the hospital as well. So it's a double-ended sword. It's not only affecting the patient, but also the healthcare system equally. So that was just about the admission in the hospital. In order to diagnose a patient with these periodic fevers, you have to talk a lot to the patient. And if a patient is an immigrant or has language barrier, this road becomes very, very difficult to take. And the same thing happened with our patient. Very easily said, the first thing that you have to do is take a good history and ask, what were the pattern of fever? Did you have any infection? This itself took quite some time for us to understand because the patient was not the best historian. And also with the language barriers, even with the live interpreter, it became sometimes a challenge to understand what they meant when they were talking about their disease. The second thing that we have to do is to rule out cancer. As easy as it said, we don't know where it was sitting. So we almost had to scan each and every part of the body to understand where it was rooting from. And after the diagnostics, as you can see on left side, now at least we are rest assured that there is no malignancy and it was autoinflammatory disease. Genetic testing, easy, right? You say that we need to do a genetic, it's a genetic disease, do a genetic testing and we'll get to know the answer. It's not that easy because most of the hospitals don't want to do genetic testing inpatient. They generally prefer to do it outpatient, and outpatient, this patient was nowhere to be seen. Family histories. Family history is very important, but how would you know a family history of a disease that is so new that the patient doesn't even know that if anyone in the family was suffering from it? So that was another challenge, because if you ask if anyone in your family had fevers, yeah, everybody said yes. Everybody, each of the every family member said yes, there were a lot of fevers in the family, but also they came from Guatemala. That is a place where there is a lot of infection. So family histories also were not the best for us. And also recurrent blood work, we had non-specific markers that elevated CRP. The patient always had elevated inflammatory protein when we came. So the slide that looks so easy when we are presenting was a big challenge for us to diagnose. So every time the patient came, we did a lot of workup for her. This is a snapshot of all the imaging the patient has actually underwent till date. As you can see, the patient has got 13 body CT scans, 18 chest CT scans, and 12 neuro studies. And just taking a little bit of average around what these costs, you can see it on the left side, what the costs are, and just think about how much this would have costed the hospital depending on the numbers of it. This body CT is somewhere ranging around $482,000. She got 13 of them done. So think about how much of an economical burden it is putting on the hospital and as well as the patient. It's not easy to get a body CT scan or a body MR for the patient as well. It puts a lot of pressure on the family as well as the patient. We had to talk to the patient a number of times, just saying that she always told us that, I got it done last time. Why are you doing it again? And it sometimes, I would not lie, it was hard for us to explain why. So after all this, in 2 to 3 years, we were able to make exemptions for her, get a genetic testing for her in-house, and we, depending on how she was presenting and the pattern of her complaints, we were able to make a diagnosis of periodic fever. And I'm not putting a name of what kind of periodic fever because still we don't know what kind of autoinflammatory disease she exactly fits in. So even though we did make the diagnosis, we were still hitting the dead end. And why so? Because once you make the diagnosis, you next have to decide what treatment and will the patient be able to afford it. So we were yet again back to where we were at square one. Every time the patient came from 2018 to 2022, we know it's an autoinflammatory disease. We can treat it with steroids. But as you know, steroids are no good. Steroids can be good for a very short period of time, but then once the steroids are tapered off, the symptoms come back. So we were able to give her steroids all the time when she was in house, and then give her a good RX prescription so that she could buy it over the counter for at least the time she was seeing us on outpatient basis. This is another medication that works for most of the periodic fevers, especially FMF. So we wanted to give a trial of this medication. As you know, colchicine was very cheap, most cheap than a candy in the past. But however, there has been a very big inflation in the price of colchicine nowadays because of its so active use in gout and other inflammatory diseases, that now the prices are very high. So we thought maybe we can ask the patient to start on colchicine, but unfortunately, the patient could not even afford this. And looking at the big ones, or our mainstay of therapy for some of the autoinflammatory disease, are the biologics, or the more complicated ones like TNF inhibitors or IL-6 inhibitors or IL-1 inhibitors, that are most of the times given to the patient in an injection form or an infusion form, were the other options. But as you can see on the bottom of the screen, that was the cost of each of the biologic. And with her immigration status, this was very difficult to achieve or even to try for the patient. Another side of it was, how would you establish the patient to get these medications when we are unable to see this patient outpatient even for once? So right now, even when we have the diagnosis, we know how to treat with the patient. Still, at least till the last admission, we were not able to treat the patient. So before I go ahead and talk a little bit what we did for the patient and what were the strategies we applied for our patients to at least make her healthcare better, I want to talk to you about who are undocumented immigrants, because it took me a lot of time to understand, because we thought, oh, there are so many NGOs, social group programs in the healthcare system that would help the patient. And every time we thought this and signed off on the patient. But this time when we were on service, we thought, let's take the matter in our hand and understand what is the effect of the immigration status in the healthcare of this patient. So undocumented immigrants are basically foreign-born individuals who are residing in US but without an authorization. This group includes individuals who entered the country without authorization, and individuals who entered the country lawfully but stayed there after the visa or the status expired. Why these people are important to us? They have a very, very less access to service, employment, resources, because they're not included in any of the policies that are available. These people undergo racism and discrimination a lot because of the language barriers or because of their status. Otherwise, they also have behaviors to avoid deportation. This patient, at least when I can talk specifically, comes to the hospital only when she is peaking in terms of her symptoms. For the first 1 week, when she knows that the symptoms are about to happen, she sits, even though she knows she's going to be very, very ill in the next few days. She does not want to come to the hospital because she's scared at some point that she might get deported. Other than that, there is a very big fear of increasing social exclusion. While I was looking in this matter, I came across this Henry Kaiser Family Foundation, who talks a lot about the healthcare system in the patients who are non-citizens. And as you can see, I will not go into depth about it, but as you can see, undocumented immigrants make a 46% of patients who are uninsured. So that limits their healthcare access. Other than that, these patients also are one of the biggest group who are the sole earners of the or full-time workers in the family. So they have no time to come to the appointments, even if for some reason we make it. And then they also make a very big group on low income. So these people, even if we have to give some medication that they have to pay it from out of pocket, it's a challenge. So this chart, I just wanted to put in to tell how much it is difficult to get healthcare system closer to them. And this is something that I looked into when I was talking to the case managers or the social workers when I was talking, because a lot of our patients, we do have a lot of the other patients who come to our clinic uninsured, and we are able to provide them like, you know, medications and diagnostics and everything on outpatient basis. But why was there such a big struggle when it came to this patient who was an undocumented immigrant? So as far as I looked at the programs, my patient was not eligible for most of the programs that are listed in here. So that was it. That's why it was very difficult for us to arrange anything possible. And as you can see, the Medicaid, she was only eligible for emergency Medicaid, and that's what she was doing every time she was coming to the emergency department. So I hope I'm able to tie what how we are not able to connect the treatment that we require for the patient as well as the healthcare that is there. So talking about what we were struggling in this patient was, first were the patient problems and then the hospital problems. It was not like it was just one-sided problem. Both the sides were facing a lot of difficulties. So what we decided was, let's treat what the problem the patient has, and that in will help the hospital as well. So the problems that we were facing from the patient side was, we were dealing with a rare disease, so it was very difficult to manage, understand. Second was language barrier. Third was a low socioeconomic status. She was the sole earner of the family, so it was very difficult negotiating her time off work. They did not own a vehicle of their own, so lack of transportation was another problem, because there were no services that was provided to her that would pick her up from the home and bring her for an appointment. Lack of proper medications, because she couldn't afford much medications from out of pocket. Frustration, recurrent hospitalizations, recurrent calls from so many people had led to frustration, that there were a big phase in time where she actually would not take any calls from Rhode Island Hospital or any of the doctors. Now, what the hospital was struggling was prolonged stay in the hospital, and the entire bill of the hospital was going, entire bill of the admission was going on the hospital. Diagnosis, every time she came, she got a lot of diagnostic tests done. All the cost paid by the hospital. They always have to follow a safe discharge protocol, which was very difficult for this patient to attain. So that resulted in even longer hospital stay, because they couldn't have a safe discharge plan for her. They had to give her coupons, sometimes free samples, and enough medication, so that when she sees all the doctors on outpatient basis, she had enough medication so that she doesn't flare. And then the tireless redundant tests that were supposed to be done each visit as a part of the protocol. So we were like, we had the problem right in front of it, and rather than dealing it like a dead end, we thought to deal it like an opportunity, and we thought to see the light at the end of the tunnel. So how we dealt with her, so it was basically the disease that we were dealing. So this time we printed out a lot of cheaper scripts, gave her free samples, and then discharged her, so that she could reach us back and tell us that if she was out of medication, we could provide her some more. We involved social worker and case management to help the patient as well as the family to deal with this situation financially as well as personally. There is an Arthritis Foundation outreach mission, which provides financial as well as other support to the patients who are dealing with rheumatological diagnosis. We were able to involve her there. And then we arranged a family meeting for her this time. And the reason why we arranged a family meeting was, a lot of patients, family members start thinking that the patient is just trying to get off work or trying to get off responsibility by pretending to be sick. And this was a very big taboo in her family also. So we did arrange a family meeting and tried to talk to the patient's children, siblings, and everyone to help them better understand and get as much help as it was possible. We educated the patient that this disease was a real thing, and we had live interpreter with us to make her better understand that what was going on. And we asked her to join local groups that were available in Rhode Island that were also dealing with autoimmune or autoinflammatory disease, maybe from the same ethnic population, to better understand that she was not the only one who was dealing with this disease. And then clearly she couldn't fit in our daily schedule of 8 to 1 clinic, so we did modulate our plans and saw her in the clinic late in the evening, or at least did telemedicine appointments or phone visit appointments to make sure that she had enough medication so that her disease was staying calm. So this was my case, these were my challenges and our approach towards how we dealt with this patient. I would like to end my today's talk with a very happy note from Lin Yutong. Hope is a road in the country. There was never a road, but when many people walk on it, the road comes into existence. Thank you for your time, everyone. I hope that I was able to present some reality facts that we deal on day-to-day basis in the hospital. I will be more than happy to answer any of your questions. Thank you so much.
Thank you so much, Dr. Monia. This was a very enlightening talk and very relevant to the topic of social justice, given that you dealt with undocumented immigrants. I'll just open the floor to questions, even though like Chenzo is here and we maybe we can wait a few minutes if there are any questions on the floor and then move on to Chenzo's talk.
Sure. And the team has my email address. If anyone has any questions or as much as I can help, I'll be more than happy. In the chat box, maybe Arushi or someone can provide the email address of me because I took almost all my time talking.
Yeah, no worries. Thank you so much. It was a very informative presentation.